So before I start, just to give you a quick introduction, I think a lot of you will have seen us before, but we do spend an awful lot of time trapped on the business park in Oxford, so we're trapped in Jubilee House, so it's lovely today to come and talk to so many of you. We commission all the screening and immunisation programmes that the NHS endorse, and that includes 16 immunisation programmes that you'll all be familiar with. And again, Andy and Joe have already showed you how complex those schedules are and how many changes have happened over the past few years. And we're responsible to help you implement those changes, and it's certainly not straightforward. Our role is to help you deliver high quality and safe programmes, but also to work with you to look at maximising access to those programmes and reducing local inequalities. And as I say, this is what our presentation is hoping to do today. So we're going to look at 3 key programmes to give you a flavour of those variations. We're going to look at seasonal flu, pertussis and neonatal Hep B, and look at 3 key ways that we as commissioners are trying to tackle some of those inequalities. So that's through the services we commission, also through our partnership working with you and other stakeholders, and what we can do with community engagement at a local level.
Sorry, it's quite difficult to hear.
Can you hear me better now? So first of all, we'll look at flu immunisation, and that is the programme for us where we've seen the widest variations in uptake across different eligible cohorts. And I'm going to share with you some examples of what we've been doing to commission services in secondary care. So I realise a lot of you are from primary care, so I thought it would be important to share some of those examples from a hospital setting. So this graph, I'm sure you'll all be familiar with, around flu immunisation uptake in the southern region. This was the uptake last year. We're still awaiting final publication of this year's data. And this is showing you uptake across all the area teams in this local patch. I don't know, are you able to see that graph clearly enough? This is showing. The very long blue lines show the over 65s. So the long blue lines are the older people, and we know on the whole they're pretty good at turning up every year for their vaccination. It's a day out, they go with their friends. We recognise it's an awful lot of work for practices to vaccinate in a very short time period. So we do well with the over 65s, although there's still room to do better. Where we're concerned is the under 65s, so those in clinical risk groups, so people with long-term conditions such as heart disease and diabetes, and also pregnant women. I think it was since 2010, pregnant women were included in the flu vaccination programme following the pandemic, where it was shown they were particularly at risk. So these are the groups that we need to look at commissioning, additional services to make that vaccination more accessible. This graph with a lot of lines on it, what this is trying to show is the variation in uptake in the under 65s across Thames Valley. So each line shows the range of uptake in a CCG, and the triangles show the average uptake. So the triangles from that, you can see roughly about 40 to 50% of people in clinical risk groups have a flu vaccination every year, but that can range from just over 10% to just under 70%. Now Oxfordshire has got the biggest range, that's the biggest CCG, so there's around 78 practices I think now in Oxfordshire. We think there may have been an anomaly at the bottom of that line, so we think there was a practice with some data cleansing issues. We're looking at the data this year to see if that variation has decreased, but that just illustrates to you the wide variation we've got just within Thames Valley. This graph is showing the flu vaccination uptake rate for the 4-year-olds. So the children's flu programme is relatively new, it's been going a few years. This shows the very wide variation, so this is much greater than the under 65s. You can see that the wide variation both at CCG level and within each CCG, the lowest rate is under 10% children vaccinated, whereas the highest is up to 80%. So what we'd like to do, is work with you more to try and decrease that variation and really move up some of those lower rates to reach the medium. This graph here is showing uptake in the under 65s and those clinical risk groups over the past 2 flu seasons. The blue lines are the flu season 2 years ago, and you can see the green lines are slightly higher. So there has been an increase in uptake of flu vaccination in that group. And looking at our data this year, it shows that that has increased even more. So that's really good news. Where we're concerned is to do with the red triangles. So they show the relative risk for mortality of flu related to each of those clinical risk groups. The lowest mortality is those with diabetes, and you can see they're the group of people that are most likely to come to you and have their flu vaccination. The people with chronic liver disease, who've got a relative risk of just under 50, are the least likely to attend for vaccination. I also want to point out, because I'm coming back to them later, those with chronic kidney disease, their relative risk is 18.5, and roughly just under half of those currently attend for a flu vaccination. So I want to highlight a service we put in place this year to try and address that. But the message here is those really that are most likely to die from flu at the moment are least likely to have the flu jab. Now nationally, there's been a lot of work to make the flu vaccination more accessible, and over the past few years there has been a new service which enables community pharmacies to deliver that vaccination programme. This pie chart reflects the proportion of people from each group who had vaccination pharmacies in Thames Valley last year. That was over, let me just check my data, I think that was that was 232 pharmacies, and that was just over 80% of pharmacies in Thames Valley. They gave just over 20,000 vaccinations. The biggest proportion though, so 2/3 of those vaccinations were in the over 65s. So what we did was provide more choice, but actually a lot of the people that already get vaccinated went to their pharmacist instead of the GP. What we ideally want is more of those people less likely to be vaccinated, to the pregnant women and the under 65s to go to their pharmacy. Only 2% of the pregnant women vaccinated had their jab in the pharmacy last year. Now we know that any new service takes a few years to get embedded, so what it will be interesting to see is if this profile changes in future years, if we'll see more people at risk attending their pharmacy for that vaccination. So what I want to do is just go on to talk about some of the services we've commissioned in Thames Valley in secondary care. Our main service has been within maternity units, and this table shows the number of flu vaccinations that have been delivered in those units over the past few years. The commissioning was started in a PCT a few years ago, and that service was set up in 2011 in the largest maternity unit in Thames Valley. And you can see year on year the number of vaccinations increased. However, it has plateaued over the last few years, and you can see this year, although it is only provisional data, that number has dropped slightly. But the number of women vaccinated in that maternity unit account for 1/3 of all pregnant women vaccinated in that area of Thames Valley, so that's quite a big proportion of that group. Provider B is an interesting case. They started well a few years ago, but their number of vaccinations has dropped off, particularly this year. Now that unit has had a significant shortage of midwives. A lot of these vaccinations are provided by bank midwives, often in ultrasound clinics, and obviously that staff hasn't been available for the flu vaccination clinic, so it's quite a fragile service. And they've only vaccinated 3% of the pregnant women living in that area, so you can see there's still a very wide variation with these services. Overall, vaccinations given within maternity units is around 2,300 to 2,400 vaccinations a year. So it's not insignificant, but we hope that we can do better. because I think, as Joe said earlier, this isn't a hard-to-reach group in the population. They access health service an awful lot. So we need to make sure that more than half of women who currently are vaccinated at the moment get the jab. I doubt you'll be able to see the true glory of this graph, actually. What this is trying to show, each of those groups of bars is each of our maternity units and the population of pregnant women they serve. So A, the group of bars on the left, shows that big maternity unit, and it's showing the proportion of pregnant women who live in that area that are vaccinated every year. So you can see over the 6 years that service has been running, the number of women vaccinated has increased. There was one little blip, but overall it's gone up. Each of the other groups of bars shows the dotted lines. For the first 3 years, in each of those other areas, there was no vaccination service within maternity units. So it's a mixed picture. You can see for provider B, where the maternity unit has been struggling, the vaccination rates have varied. In the past 3 years, they've gone down. And this includes provisional data this year, so it isn't as good news for that area. I just want to point out with provider D on the right, that is a maternity unit serving our most diverse and deprived population in Thames Valley. So although the vaccination rates are lower, I think it's heartening to see they are going up year on year. This graph shows overall the vaccination rates for pregnant women in Thames Valley. So the blue line is Thames Valley, and you can see we're about 2% higher than the England average, which is the red line. Still a dotted line in red because we still don't have the violent data this year, but you can see overall we do better here than nationally, but we do follow the national peaks and troughs quite closely. So it's interesting to see how that pattern is matched. So moving on to some other pieces of work in secondary care. This is an example of a flyer this year that was given to all occupational health departments in our hospital trust where they vaccinated their staff. Because you know, most hospitals, it's a very well-established service now for getting staff vaccinated, and we wanted to make the most of the opportunity for staff to share the importance of vaccination with their patients. This was for staff to understand that there are a wide range of patients who require vaccination and to promote that within their clinics. It's a very low cost, but an intervention that can reach an awful lot of people. So it'd be interesting to look at the impact of that. And this is a summary of some of the work we've done in secondary care. So I've talked about maternity units and that staff flyer. There's also been a lot of displays in outpatient departments. And interestingly, this year we've been successful in getting a message on the footer of a lot of clinic letters that are sent from outpatient departments to patients and their GPs. And they're disease-specific letters, because what we've had in feedback is that people don't really associate themselves with having a long-term condition and being eligible for a flu jab. So if you now go to a liver clinic, you're going to get information about if you've got cirrhosis or hepatitis, the importance of having that vaccination. It started quite small this year. It's focused on clinics for people with liver disease, kidney disease, immunosuppression, and I think there's opportunity to develop that more widely. And lastly, I just want to mention a service that we have started this year for people with renal disease. So you remember earlier I said that they've got a relative risk of 18.5. Now that's a cohort of patients that spend a lot of time in hospital. They often visit for dialysis 3 times a week. They're more likely to access secondary care than primary care. And there was a very motivated matron of that service who was keen to set something up. This year it started small. We didn't start conversation until the middle of October, and there's a lot of planning with setting up a new service. So you need to think about, do staff need training to immunise? Is there PGDs in place? How do you get a vaccine when the flu season's already started? These type of things. They did manage to get something up and running by November and offered it to 40 patients before Christmas. What was interesting this year, there was a flu outbreak among patients with renal disease, which resulted in 3 being admitted to hospital because we know they are high risk. That led to the service giving a second offer of flu vaccination in January, where a further 10 patients took up the offer. Now, generally there's around 400 patients on dialysis across Thames Valley at any point in time. So I think if the service starts early in the flu season next year, we could get that offer and get as many vaccinated as possible. And also look at other services in hospitals where we've got people who are least likely to access primary care because they're in hospital more often. So that's a very quick run through of flu vaccination. I'm going to hand over to Nisha now to talk about some of our other programs.
My name is Nisha. I'm the other screening and immunisation lead in Thames Valley, and I'm going to talk through two programs where we really work collaboratively with colleagues, and some of you will be in the room here today. And one of the programs I wanted to focus on was pertussis, which Professor Paula and Joe have both referred to, and to show you how locally here in Thames Valley we work together to improve uptake and to reduce some of the inequalities in the local setup. So just a bit of background. Back in 2012 was when the program was introduced. It was introduced because there was an outbreak at the time, quite a few young children infected with pertussis, but also generally in terms of pertussis activity there was higher levels across all age groups. And since the outbreak was declared in April, a decision was made to offer pregnant women the vaccine from October 2012. So it's been going on for 5 years, as mentioned before. And really the aim was to reduce disease and to reduce hospitalization and the suffering that a neonate would go through if they were to be infected with pertussis. And since then, the eligibility criteria, so the gestation age at which a pregnant woman is eligible to have the vaccine has been reviewed, and JCVI has been able to give advice and recommend that it can be offered at a younger gestation age now, which is fantastic for us because that means that we can work together to improve uptake by encouraging it at many more opportunities when pregnant women are encountering locally. So the pertussis vaccine is delivered through primary care, and one of our colleagues in the team was tasked with the job of looking into why some practices had different levels of uptake, and some of you in the room may have been contacted or would have been part of some of the improvements that have happened already in Thames Valley. And some of the things that we worked on were data issues around coding of vaccinations and where where delivery date was not recorded on the system, and where the Inform system couldn't pick up the particular coding that was used in the local practice, could have caused low numbers to show up, but actually the women had received the vaccine. So there were some data issues that were ironed out. Joe also mentioned workforce issues in terms of clinic capacity and being able to run pertussis clinics within primary care. And some of the things that we were able to work through with colleagues was to introduce second appointment generation, and to some places where the antenatal check couldn't be followed through with a vaccination, they were able to make local arrangements with the community midwife to talk to the practice nurse to arrange for a woman to have the antenatal check and to follow on with an appointment with the practice nurse to have the vaccine. So there were definite communication pathways that we were able to influence, and also where a woman had booked on but DNA'd for some reason, maybe they had another appointment to attend, or it slipped the radar. There was no sort of systematic way of recalling people who had DNA. So again, some changes have taken place to improve recalling people who have DNA. And again, follow up with community midwives to be able to give that message that it is a safe vaccine and the importance of having it in the context of preventing whooping cough in your newborn. So some of the things that we did do was to work with practices by offering support, visits, phone calls, and monitoring on a monthly basis where some of the issues were. And there were targeted visits where community midwives were also involved, and we took into account coding and also talking through how to encourage pertussis uptake and getting use of the resources in terms of leaflets and posters, making them available to various places like children's centres and also to the maternity units. So the colleague who's been working on this has a midwifery background, and she's been able to link with all of the 4 maternity units because of her other role in screening as well. And we also undertook back in 2016 a media campaign. So we did a few radio interviews. There was a TV interview with one of the local TV channels, but also messages on buses, which was aligned with the flu program last year, and quite a few of those have happened, but also making regular visits to maternity units to again talk through and where community midwives have meetings to be able to encourage pertussis promotion. Month on month, it's been very positive, and this really shows how some of that targeted work may have helped. Again, I think that the national picture is going in the same direction, and I think the window of eligibility being that bit wider does make a difference. But locally, we do have experience of just making those little coding issues sorted has made a difference. So across the patch, we have seen month on month improvements. And again, this is just in terms of numbers. If we were to compare month on month what was uptake with the 12-month difference, it is pretty huge. So what we've done locally has been very helpful. So I guess from our perspective, we've learned a lot from our work locally, and it's about keeping those principles at the back of our mind so that it is stuff that we can apply to other programs and other areas where uptake is an issue. So one of the main things that we learned was the sort of technical side of things, which is really to do with how coding works and how data is recorded, particularly in this sort of program where it's automatically uploaded to the national system, and also having opportunities to increase awareness. So we've been able to make contact with the maternity units and be able to work with midwives who are that frontline staff who pregnant women come into contact with, and to be able to promote the vaccine through that, but also use media opportunities whenever we get the chance. We try and make use of it. So another example is Hepatitis B, and this program refers to the high risk. Can you hear me all right?
Yeah, it's got meant to be in just 5 minutes.
Yeah, fantastic. It is very brief. Hepatitis B, which is for the high risk women, high risk babies rather, which is for mums who have been diagnosed with hepatitis B in pregnancy, the children who may be at higher risk form part of the neonatal Hep B program. So in this program, when we sort of look at it from our 4 areas which form part of Thames Valley, so by that I refer to the 4 PCT areas that came into being Thames Valley. We did find that in terms of offering the vaccine and recording of the vaccine at 0, 1, 2 and 12 months, and the offer of the blood test to be variable across the patch. So we carried out an audit last year, which for us was a good opportunity to identify where some of the issues are. So in this one, where uptake is concerned, it does decline with each vaccine. So the older the child gets, the less likely that they get the vaccine and the subsequent vaccine, and then go on to have the blood test afterwards. So for us, the variation that we identified locally was that the quality of data across was not good, but also in terms of the pathways that were followed and the roles and responsibilities of individuals was different. And there was an opportunity for us to really get all our stakeholders together. So there's very many people who are in this room here as well, who form a very important part of maintaining and ensuring that these children go on to have their Hep B vaccination and complete the course. So we had a meeting with everyone and agreed a more robust pathway that we are now going to have across Thames Valley. So everywhere follows a similar pattern in terms of follow-up. And this is very new in place, but in terms of following it up, the childcare information system, which holds records of children's immunization, will be actively following up the attendance, particularly up until that 12-month blood test, and recording the result of it, which was one of the main gaps that we found in our audit, the recording of that. And to us, that is the sign of knowing whether this child would have got infected or not. So that's something that we will be doing actively. And also in terms of following up individual vaccinations, there'll be extra steps that are going to be in place to follow up, not in a month's time, not in 2 months' time, but in a more timely fashion. And across the patch, it'll be at that similar time scales. And this pathway is pretty much in place now, but will be underway for us to evaluate in about 6 to 12 months to see what progress has been made. But as we go on, I mean, there are sort of teething issues that have come up and questions and queries that we have addressed in the meantime. So we just put our contact details of our team so that if colleagues did want to ask any questions or have any ideas for how you might feel some of the variations can be tackled, we'd welcome any thoughts. Thank you.